I'm going to quickly start my presentation. So you all know that corneal ring segments are one of the most debatable lines of treatment in ophthalmology in general and keratoconus specifically. Um, and the most common reason that the major reason for being a debatable line of treatment is having unpredictable results. Whenever you ask a corneal surgeon, he always says presenter notes. So the problem is not the PMMA synthetic um, device that we implant that we always blame. The problem is how you plan for it, how you plan for the ICR's implantation. So whether you have a PMMA synthetic corneal ring segments, whether Kera rings, Intacs, whatever the type, or Cares, you always get unpredictable results. Not because of the ring segment itself, but because of how you plan for it. Firstly, you should stick to the general rules that we all should know, especially in the beginning when you start your practice with ring segments. So very basic rules. The K readings should not be higher than 65 diopters. The higher the K readings, the poorer the outcome, the visual outcome that you will get. The optical zone, please stick to the ring segment you are using. So we have different ring segments. We have ring segments that could be implanted, that should be implanted at 5 millimeters optical zone, and we have other ring segments at 6 millimeter optical zone. You should also know the femtosecond laser platform you are using. Each platform has different specifications, has different settings that you should know very well. So for the FS200, for example, which I have in my practice, and the one that I use, you should not leave less than 130 microns below the tunnel. Other than that, if you have less than 130 microns, you are at risk to get microperforations. The depth of the ring segments as well is very important. So for PMMA ICRs, you should go as deep as 75 to 80% depth. For CARES, corneal allogenic ring segments, according to Istanbul nomogram by Eileen, you should go 250 microns deep only. So whichever the nomogram you use, this is the one we use for the Kera rings, you should always know that these nomograms are used as a guideline only. You should not depend on it as it is, because it does not cover all the factors for different patients. So as you can see, at the very bottom of this nomogram, there's very small font, a few lines with a very small font that says that this nomogram should be considered and used as a general guideline only. Nobody reads this. It should be customized by the surgeon, and the surgeon is the only one who is responsible for selecting the implant. So you should not use the nomogram as it is. So what are the other reasons for unpredictability? These are the three questions that I always ask myself. Who are the candidates for ICR's implantation? Not all keratoconus patients are candidates. What are the expectations from ICRs, and how to choose the ICR segments? So this is a paradigm that I've created for when practicing and choosing the patients and planning for ICRs to predict to increase the predictability of ICRs, starting from patient selection, nature of the cornea, identifying the reference axis that I should implant the ring segment on, type of cone, and the K readings. So regarding the patient selection, patient's identity and patient's expectations. What I mean by that, patient's identity, the age differs. So different age of the patient, the corneal hysteresis and the corneal resistance factor changes with age. This is a very important point. And we all know that oxidative reactions between the collagen fibers occur as the patient gets older, which what we call natural cross-linking. And this is proved by many of the papers, including these two papers. This one was done in King's College London, and it was on 50 corneas, saying that the stiffness of the cornea doubles between the age of 20 up to 100 years old. So The importance of the age factor is a very important point because there's more force required for the displacement of the cone. So in clinical practice, if the nomogram says that I should use a 160 degrees, 250 microns thick ring segment, in a 40-year-old patient, I would increase the thickness of this ring segment, or I would alternatively reduce the optical zone. What about the gender? Is there a difference in the corneal elasticity between males and females? Well, this is a bit debatable, but this is a paper by Dr. Riham Allam and Noha Khalil from Asr Al-Aini School of Medicine, and published in the European Journal of Ophthalmology. And there was a statistic, it was on 350 candidates. They showed that there is a statistically significant difference between males and females in corneal hysteresis. What about the expectations? The aim is not to get rid of glasses, and you should tell your patient, please under-promise them. Do not under-promise, but over-deliver. What about the nature of the cornea? In virgin corneas, it's more elastic, but in corneal, cross-linked corneas, similar to age, the cornea is more stiff, so you need more force to displace the cone and to redistribute the regularity, to regularize the cone with the ICRs. All of these should be considered when you plan for your ICRs. What else? Identifying the reference axis. This is a very important point. Where should you put this ring segment? Should you center it on a chromatic axis or on the manifest cylinder? A very big debate. In my practice, I have been using the chromatic axis for several years, and the outcomes are much better than using the manifest cylinder, regardless the past-corrected visual acuity. And this is how you get the chromatic axis from the Pentacam, from the Zernicke analysis. What about the type of cone? Well, the ICRs are used only for peripheral and paracentral cones. I don't use it for central cones. Central cones there is a different line of treatment for it. I will just share it in a few minutes. But paracentral or peripheral cones, which bisect the pupil, are the ones which are indicated, and they gives more predictable results than the central cones. The diameter of the cone gives you also a clue on the arc length of the segment that you should use. What about the K readings? Look for the difference between the Kmax and the corresponding opposite point on the curvature map. In my practice, again, this is one of my tricks that I do. If you have a K difference of less than 10 diopters, I stick to the nomogram that I'm using. But if I have a K difference of more than 10 diopters between the Kmax and the opposite corresponding point, then I step up one more step in the ring thickness. So, in conclusion, my recipe is never ever rely on the nomogram alone. Please, never rely on the nomogram. Predictability of the results. Can I have one more minute, please? Just one more minute. I have just one more slide. I think this is the last slide, maybe. Predictability of the results. Predictability of the results of the ICRs depends largely on how you plan for it. Under promise, this is very important, but over deliver. 1 minute, please. Under promise, but over deliver. Patient counseling is a very important point. And please consider the age of your patient, nature of the cornea, the type of cone, and the K readings. Not all keratoconus patients are the same. So different keratoconus patient has different planning. And that's it. Last but not least, I'm happy to help. This is my email and WhatsApp number at any time. But remember, in life, there's nothing for free. So I would largely appreciate your dollars, okay? Thank you so much.
Thank you, dear Dr. Zakaria, for this very nice presentation. I have two questions, please. The first one, you have said, as we all know, that the Virgin Eye, which has done no cross-linkage, differs from the cornea
Yes.
that had performed corneal cross-linkage. Do you have any changes in the parameter of ICR's implantation in the comparison between the Virgin Eye and the eye which has done corneal cross-linkage?
Well, if you mean by the parameters, the settings on the femto-laser platform, there is a change on the femtosecond laser platform between cross-linked cornea and virgin cornea. And regarding the ring segment itself, this also changes. So regarding the parameters or the settings of the femtosecond laser platform and cross-linked corneas, the femtosecond laser is a bit difficult to dissect between the tissue. So I always increase the energy a little bit in cross-linking corneas, in cross-linked corneas when doing the tunnel for the ICRs. I increase the energy while performing the tunnel with the femtosecond laser. Regarding the ring segment itself, this as well, I increase the thickness. I always play with the thickness of the ring segment. So, for example, if I proposed that should implant a 160 degrees arc with a 250, I just increase it to 300 better. So yeah, I reduce the optical zone as I've just said. If
My second question, if the patient is not satisfied, when can you remove the ring?
Well, I usually wait for not less than 6 months. So we do have, I'm not saying that ICRs is the best thing in the world, but yeah, we do have unsatisfied patients. Yeah, but not less than 6 months to fully see the effect. Regarding also the question about cross-linking, I prefer if it's my patient from the start, I prefer to do the ICRs first, then cross-linking on the new regularized cornea. I don't do the opposite. Some people do it simultaneously in the same session. I prefer to do it sequentially.
Difference how much? Difference between?
Yeah, again, not less than 6 months, 3 to 6 months. Yeah.
Okay. Thank you, dear Dr. Zakaria.
Thank you.
And what will be your first line of management in central cone?
Well, here's the talk about central cones. This is Dr. Ahmed Shama's cone. I prefer to do ICL for them if there is no chromatic aberration. Central cones usually have spherical aberrations more than coma. So toric phakic IOLs or not ICL per se, phakic IOLs in general, whether toric or if it's a pure sphere, which is unlikely, phakic IOLs would be show very good results.
But stability and according to the progression or at any time? Yani you will wait مثلا 6 months
for doing phakic IOLs? Yeah. Stabilize first,
to
of course, not
stabilize.
less than a year.
Yeah.
6 months to a year.